coronary angiography is a procedure that uses special dye. That's what the contrast, what we call. And by the use of C-arm and X-rays, we will see that contrast material field in the blood flow through the coronary arteries of the heart. Okay, so this is a gold standard for any evolution of the coronary artery disease. There are so many. One is a ECG, echo, TMT, dopamine stress echo. So many things are there, and CT angiogram also there. But the coronary angiogram, the uh, invasive coronary angiogram, is a gold standard for the CAD. Even though the CT angio is positive also, we cannot tell that patient is having, unless after that we have to do the coronary angiogram. So the coronary angiogram can be used in identify exact location and severity of the. So what are the indication where you will do the all acute coronary syndrome like acute MI, NSTMI, unstable angina, chronic stable angina, and any TMT is positive, any ventricular arrhythmias are there, VTVF, or any atrial tachycardias are there, or any left LV dysfunction without any known reason. So valvular heart disease before going for the NVR or AVR or DVR after 40 years. Pre-operative coronary assessment for cardiovascular surgery if it is a major surgery and you have found that there is some ECG echo changes, and normally periodic checkup after cardiac transplant. So the contraindication that is a very important is contraindication is coagulopathy, active bleedings, malignant hypertension, acute and chronic renal failures. In that, if the patient is on hemodialysis, then you can go ahead. Otherwise, you have to use the contrast VCPAC. Severe anemia, electrolyte imbalance, fever, active systemic infection, uncontrolled rhythm disturbances, arrhythmias, uncompensated heart failure, and TIA. At least you have to wait up to 1 week. Patient unable to cooperate or does not desire procedure. These are the things are contraindicated. What are the things required for the coronary angiogram? Cardiac cath lab is required, puncture needle, and introducer, short guide wire is required. That short guide wire is different. Sheath is required. Normally we take five friends for the coronary. For diagnostic, for the PTCA, we take 6F. But because we are using only G material, they don't have 5F, most of the center. So they take even 6F for both diagnostic and for the PTCA. Then for the hooking, Judkins TIG catheter, Tiger catheter, Judkins catheter for the left side, right Judkins. Now for the radial, we take it TIG, TIG. Okay. And contrast media, usually we take ionic contrast if the kidney problem is there. Non-ionic contrast is VCPAC. This is how you look like the Judkins, Judkins 3, 3.5, and the 3.5 MOD, 4, 4.5. This is the Judkins. All depend upon the primary curve and secondary curve. The short segment is this one soft. So this how you look like left Judkins and right and left. This is for the right and this is for the left. Okay. All depend upon the, this is the primary, secondary, tertiary. The angle depend upon the angle. You take it 3, 3.5, 4, and all depend upon the how big is the aorta. You have to choose as per that. This is the right Judkins. This is the TIG which I have told for the only for the radial approach, not for the femoral. This Judkins we take it for the femoral approach, and this TIG the Tiger catheter we take it for radial approach. So radio contrast, which I have told, first generation is ionic, hyperosmolar, 1400 to 1800 milliosmolar per kg compared with osmolarity peroxima. Why everybody has to know what contrast they are using. So it's an isolated radio contrast agent, are either ionic or non-ionic. So what are the advantage, disadvantage for that? We have to know that. So this is the first generation ionic. Second generation ioxihol. This is a non-ionic monomer, low osmolarity. Then the first generation Wherever first generation is having 1400 to 1800, his osmolality is 500 to 850 compared with plasma. So this why this is so easily observable through kidney and excreted. So this is little bit safely VCPAC. This is little bit safely given in kidney disease. The newest non-ionic contrast now is isoosmolar with the osmolality approximately 290 to 300. So iodoxanol agent. This is the newest non-ionic contrast. Okay, how to? There are a few steps. So pre-cath, we have to take a written consent, at least 3 hours of fasting. Pre-cath investigation is a must. So what are the viral marker like HbA, HIV, HCV? We have to know the hemoglobin because patient is having anemia or not. Sugar level we have to know. Creatinine level, urea creatinine we have to know. Electrolytes we have to know. So these and I think I have told everything. A basic ECG, echocardiography. These are the pre-cath investigation you have to know at any cost. Okay. So the selection of the arterial access point, we have to select whether if it is a radial approach, it is a easy to the patient and easy to the operator. Saving the groin wrist according to the choice. Opening the IV. One IV cannula is a must before taking for angiogram. Connect with the cardiac monitor. Any local anesthesia usually we give at the site.